title of this section is Translating the Joint Position Statement into Real System Changes and Improve Safety for All. And this morning it occurred to me that with all of the AV issues, I didn't really fully introduce myself. I also, in addition to being a physician and an EMS physician, medical director, am also a paramedic. Have been a paramedic for 40 years now. And I do still go out in the field in sort of both capacities to some degree, as a practitioner as well as a medical director. So not to rehash, just to introduce, what we want to do now is take a deeper dive into some specific things you can do in your communities. And I realize we have a very mixed audience. We have some EMS practitioners in the audience. We have some managers and chiefs. We have community people that maybe don't have a lot of specific medical knowledge. So I'll try to hit something that works for all of those groups. This article was actually among Matt's articles that he put up there earlier. I'm going to take a little different slice at it, though, because I was actually doing a research data workshop last week with the NEMSIS data, and some of what we were doing referenced some things that were in here. And as I went back into it, I found that there is a gem within this article that very few people ever talk about. So that's what I want to hit. This is this article by Jeff Jarvis et al. And their goal was to describe the frequency of 911 calls that result in these potentially life-saving interventions. What you have to realize is that their definitions of potentially life-saving interventions were very, very liberal. You could take a look at a lot of them on the list and say, if we get there 2 or 3 or 4 minutes later, it's not going to be life-saving to do that intervention. So they tried to keep it very broad. So with that, their results are actually, if anything, weighted to overestimating the results. But what they found in almost 6 million calls using the ESO data set at an ESO workshop was that 86% of those got lights and siren response, but only 6.9% had the potentially life-saving intervention. That's what everybody else talks about. That's what Matt talked about when he showed the slides related to this. But again, there is a real gem in here that nobody really talks about. And that is, they list the highest type of call that got the potentially life-saving intervention. And you could imagine that, like cardiac arrest calls, there were a lot of potentially life-saving interventions there. So some of the calls had a significant percentage. 6.9 was the average for all calls. But look at these. We were talking at dinner last night, and the abdominal pain thing came up. Like it was sort of a new idea that abdominal pains don't have a lot of life-saving interventions used on them by EMS. But way back a couple years ago, this article had that buried in there, that 0.8% of the abdominal pain calls that EMS goes on has one of those potentially life-saving interventions. So, when we're talking about how you, as a community, start to take some bites at this apple, the first thing that I would say, and we've said a lot about lights and siren is a good place to start, because if you're not ready to reprioritize and say, we can take an hour or 90 minutes to get to that call, as you've heard, well, then start with the simple things and take 3 or 4 minutes longer to get to some of the things that you don't actually need to go emergently to. And this is a great list to start from. And I will tell you, I'll point out another part in here, and I have to watch what I say because this is sort of embargoed, because one of the things that a group that I was working with at this NHTSA NEMSIS project, this one didn't use ESO data, it used NEMSIS data, and we were looking at the specific question of responses to motor vehicle crashes. And many might think, if you're in public safety, that the last thing, the very last one you would go to, maybe short of cardiac arrest, lights and siren, would be you wouldn't give up going lights and siren to a motor vehicle crash, right? But in Jeff's study, you can see that traffic accident had a 3.7% chance of use of one of those patient life-sustaining injuries. The issue with that is that this study that he did required them to have gotten there, evaluated the patient, transported the patient, that kind of thing. It doesn't include all of the ones that you go to where you're canceled, refusals, etc. So in reality, what we found was we reran this with NEMSIS data and found that less than 2% of, and it's, I don't want to give the specific figure, it's significantly less than 2% of the, and I just do that from an academic standpoint. You know, we don't want to present research results until they're fully put through and vetted and that sort of thing. But less than 2% required one of these potentially life-sustaining things. Several fire departments have already done this. Wichita a number of years ago, or not fire departments, EMS. Wichita EMS stopped going to motor vehicle crashes, lights and siren several years ago. And the idea was the vast majority are sign-offs. When they're not a sign-off, the vast majority of those are BLS. And the ones that are truly seriously injured, fire gets there first. They're not blocked in by fire vehicles because they got there sooner. And you know, they need to extricate the patient and do their care anyway. So it really didn't affect their care. So this is a good one to look at if you are trying in your community to say, where do we start? Stop going to medical alarm activations, lights and sirens. Stop going to abdominal pain. Stop going to, you know, some of the ones on this list. And I would encourage everybody to look at your own data. You know, I think that every time people look at their own data, they seem to find the same data. But it works much better when you look at, like Stein Bronsky did in Colorado Springs, look at your own data cards from your dispatch and figure that out. The other place that did almost identical to what Stein did is up in Niagara Falls, on Canada, Ontario. They did the same thing. They looked at all of their dispatch things, and they didn't give up at, okay, Charlie calls are going to go this way, Delta calls are going to go that way. They looked at every single individual card. And when they looked at those individual cards, they found that there were some within categories that maybe had sicker or less sick patients. They have an advantage because they have universal health care, and the EMS in Canada is part of the universal health care, part of the National Health Service. So they were actually able not only to get information like how often they did a patient life-sustaining intervention, they were able to get the actual hospital outcome from all of their patients and who really, you know, was significantly ill, needed to be admitted to the ICU, et cetera, and who was not. So one approach is to do that. Remember, we had those 5 examples, and we talked about clinical and safety and operational and experiential. I'm not going to talk about those specific things. We could take any of those categories and dive a little bit into what we can do to start moving the needle. But I want to talk about sort of 2 that are in these examples from the clinical. And one is the CARES database that you already heard Dr. Daya talk a little bit about. And the other one is the NEMSQA, published NEMSQA quality measures. You know, those are ways to benchmark yourself against others, and they're nationally picked measures. So if your agency is trying to pick things and then go to your, you know, city council or that sort of thing and talk about how good the care is that you're giving, well, you know, pick the national measures that have been vetted nationally and particularly the ones where you can benchmark yourself. If you don't measure things, you don't have any data. You can't just go into city council and tell them you're doing a great job and doing great clinical care. You have to have some data to back you up. And not only data, but benchmarking to others that are similar to you. So here's an example of, I love this picture. We just took this last week. This is one of my paramedics and her child. But we were doing some pictures for a pediatric textbook. This is an example of some of the NEMSQA data. There are NEMSQA items under safety, under pediatrics, under trauma, under you know, various components of care. But this, one of the pediatric ones is basically related to how often you're using pediatric specific restraints in the back of your ambulance. So it's pediatrics, it's also safety. There are other pediatric ones related to using the proper weight measurement of your pediatric patients and dosing correctly. Dr. Fales is sort of like the national leader for doing, and Dr. Hoyle over on the western side of the state, doing some incredible studies showing how poorly in EMS we give pediatric dosing of medications. And so concentrate on those things that are important, and we have known metrics for. In the safety metrics, there you'll see what we've been talking about all morning, things like tracking your lights and siren use and lights and siren transport and that sort of thing. As just a couple other examples for people that aren't familiar with the NEMSQA data points. Here's a simple NEMSQA data point for syncope. What is the percentage of EMS responses that come from a 911 request for a patient with syncope, which for the lay people is like passing out and then being awake when shortly thereafter, spontaneously, during which you get a 12-lead ECG. So it's sort of a standard that if you have somebody that passed out, had syncope, and is awake before you now, and you don't have any other reason for it, you should do a 12-lead ECG. So how often is your agency doing that? Maybe if they measured it, they would find that you're really only getting it like half of the time. Or maybe you'll find out that they're getting it 99% of the time. These are some of the trauma ones, and there are a number of trauma ones in there. Some of them are related to the CDC guidance on which patients should go to a trauma center. If you look at all of the patients that met mechanism or blood pressure or Glasgow Coma Score, motor component criteria for going to a trauma center, how often are you actually getting those people to a trauma center? So this is just a little bit of an example of some of those metrics. There are others. I just pulled a few out there to give you an idea of things that your system can be looking at in addition to or beyond the lights and siren. And again, I don't think that we should throw out lights and siren. Nobody here today thinks we should not do any. I think that if you've got a potential cardiac arrest, it still makes sense to get that to that patient a couple minutes faster if you can, and that may make some clinical sense. But I would say that if you're tracking your response times, what you should be tracking is your response times to those highest category patients that might be a cardiac arrest, and not tracking them to all of them altogether. So, what are those things where minutes do still matter probably? Cardiac arrest, respiratory arrest, choking, life-threatening bleeding, that kind of thing. For all others, the emergency should be over when EMS arrives. And actually we had a conversation at lunch about a patient that had gotten defibrillated multiple times and then was taken into the hospital and went into VFib again. And in the hospital, there was a big delay in recognizing and defibrillating them. EMS sometimes is the better place for some of these patients. They sometimes actually get better care when they're with EMS than they do in the emergency department. So, but that's just more of the idea that, you're trained and qualified in EMS, and the emergency should be over most of the time when you get there. And so the emergent transport, emergent responses aren't as important. So I did want to talk a little bit about CARES. A couple of us in this room are, Bob Swore left, but Dr. Swore is on the CARES board as well as myself. And, CARES is a way to benchmark your work in cardiac arrest care. In the few patients you should be going lights and siren to, probably, how is your EMS agency performing? The response time to your cardiac arrests is not the best indicator of whether you're giving good cardiac arrest care. The best indicator is how many survivors of cardiac arrest do you have in your community, and how does that compare to similar patients in other communities in your region, your state, and the country. I don't think, Bill, last night, did they get regional data in Michigan? Okay, so rather than regional, it's medical control. In Pennsylvania, our regions are generally multi-county. You have regional too? Okay, so agency, medical control authority, the region, and the state, and then of course the nation. So, that's very telling. If you can look at your results and your survival results, because, unfortunately, for most of what we do in medical care, we can't point to it and say, oh, we did a great job, we're saving lives there, because we don't actually know the survival statistics. We only know, whether we did that 12 lead in the syncope patient, or, somebody that was seizing in status epilepticus might have gotten a benzodiazepine, et cetera. But in cardiac arrest, we can actually get to the how did you really do? Did they survive, and did they go home to play the piano? Which is what's really important. So the benefits of these out-of-hospital cardiac arrest registries are that you, number one, get improved data collection because your agency has to collect and submit the data. You get this comparative analysis that we talked about, and you can look at it longitudinally. In my agency, we have been watching and participating in CARE since 2013, and we not only get our annual data, but we also look at it longitudinally. And I like to look at it in cuts of like 3 to 5 years, because that's where you're going to see the real trends. Unless you are in a system that is doing hundreds of cardiac arrests a year, and you're going to really be able to compare one year to the next. If you got a little less than that, you really have to compare them in about 3 or 5 year chunks to really know and see what direction you're going. So CARES basically also is measuring a whole bunch of things about your EMS and your community that you need to be involved in, that don't just rely on you teaching your people how to handle a cardiac arrest, because they can be the best in the world at handling the cardiac arrest. But if somebody doesn't have early recognition, if your dispatchers don't start somebody on compression-only CPR, if there's nobody there that knows CPR, if there's not a public access defibrillator, et cetera, your results are going to be a little bit lower. And the other important thing is that the CARES data ties right into the hospital outcomes. The hospitals have to participate and put data in to match your data and match your patients, but it then gives you these reports. Let me ask, before I go a whole lot deeper into CARES, how many people here in their agencies are participating in CARES and are aware that they get their CARES data back and regularly see it? So we've got maybe more than half of the people in the room. Now the questions I would ask too then is, who sees it? Is it your manager that sees it? Is it your medical director that sees it? And is it shared with everybody? Because to me, if it goes to the manager and they don't even share it with the medical director, then yeah, they see what's going on. They're not going to drive the needle in changing your system unless the people at the ground level understand how important it is to do the things that are in your protocols and in your system of operation for cardiac arrest. And you really have to engage everybody. So, I would recommend that not only, the medical director and manager should see it initially, should do a deeper dive into it, should see what they want to improve upon with it, but then should be sharing it out every year with everybody so that everybody in the organization knows how you're doing and knows if you're less than the regional average or greater than the regional average, and if you're up from last year or down from last year, that sort of thing. This is just to give those that don't know what the national numbers look like. Nationally, about 40% of patients get bystander CPR. Nationally, about 11% of patients have a public access AED used on them, not by a first responder, but a true public access AED. Survival rates to hospital admission nationally are around a quarter, 25, 26%. Survival to discharge from the hospital around 10%. Of course, everybody in your community that watches television thinks this is 100%, but realistically, it's about 10%. We had a little hiccup through COVID. We were doing better, and then it dropped back with COVID. So, it also is something that has helped us track things like the pandemic and what was the effect of COVID on our survivals, et cetera. But they have been climbing up since then and improving steadily year by year after that. But then, not only how many survive to leave the hospital, but about 8% survive with good neurologic function. They can go home and play the piano even if they didn't play it before. I'm just kidding. But they go home and they can live independently and they can do their activities of daily living and that sort of thing. And the amazing part about the CARES database is the number of missing data is exceedingly low. And actually, if your system doesn't all participate together to get your data in, if your hospitals don't participate, et cetera, they will not give you an individual report if the amount of data that has come back does not reach a very tight threshold, less than about 1%. If you're missing more than about 1% of your data, you're not going to get your report. And then this is the Utstein survival, which is those patients who somebody saw them go down and the patient had a shockable rhythm, got a shock from a defibrillator. And you can see that those are higher. So that's the group that is most salvageable. So one of the things I wanted to point out is that CARES is a really interesting tool for doing things even beyond that. We talked about earlier today that our EMS care should be equitable. And this is from the Chicago area. And basically, it's these little municipalities within Chicago. And what it shows is the bystander CPR rates over several years and over some efforts that were going on in those years to try to increase community CPR and bystander CPR. But you can see that there are pockets of places where the bystander CPR, chance of getting bystander CPR is very low, and pockets of other places where it's very high. And people have actually mapped these out to socioeconomic differences between those areas. And it's becoming more and more known that we have some of those disparities too, that if you live in a lower socioeconomic area, you are less likely that somebody's going to do CPR on you than if you live in an affluent area. And these are bystander CPR rates, not by the rescuers. So the CARES data allows you, those of you that are here for representing communities and that sort of thing, there are other things that can be done with this to take a deeper dive into your community if you were inclined. And some of this can help, as it has in places like Chicago, help target things like grants for CPR training into certain areas in your community. So lots of good stuff you can do if we look deeper into the data than just how fast did we get there. This is just quickly, you're in Michigan, which, and I think probably the entire crowd here just about is Michiganders, other than maybe Mo and myself. But you're fortunate, Michigan is one of the states that's in the statewide programs. CARES is still working with about 13 more states that are not yet in the program. And I think that map is updated by one or two yet. And the future goals for CARES are that by 2027, we will have the entire country covered with every state participating in CARES statewide. And I'll point out also that CARES is an entity that initially was started in conjunction with the CDC, but now is basically a multi-agency sponsored thing, and they have lots of public-private partnerships with some big associations and others that are interested in cardiac care, like the Red Cross and the American Heart Association and various EMS organizations, public health organizations, et cetera. So, Bill, I think it's time for some info from you.
Yeah, thanks, Doug. Do you have a clicker?
I do. I was going to.
Can you be my clicking clicking person? Yeah, I can handle this.
I think that Colby said that he has a little electrode on you somewhere.
Yeah. So I'm the last one before the great panel discussion. And so I think Colby's expectation is that from the talks today, there will be still enough energy left in the room to throw some tomatoes at Colby, or to challenge some of the things you've heard, certainly to ask questions. So, so just to follow up on Doug, what I'm going to try and do is pull some of this stuff together that we've been talking about and give an example for my own system. In addition to serving as a state medical direction consultant for Michigan, I also am the local medical consultant for Kalamazoo County. So we're going to try and give an example of how we made a relatively small system change with our response times and how that impacted or how it was associated with our cardiac arrest survival. So it produced some findings that I thought were pretty interesting, and hopefully you will as well. A list of disclosures, I don't think any of these are, there should not be anything that would necessarily be a conflict of interest. My day job is at Western Michigan University School of Medicine, where we were until recently very proud to have Dr. John Kramer as one of our faculty. And just a quick disclaimer, although I am the state medical director for Michigan, these are my views and don't necessarily represent the views of our department. So cardiac arrest survival, after increasing advanced life support response time performance targets in a countywide EMS system, that being Kalamazoo County. So to get an appreciation for this, you have to just bear with me to give you a little bit of information on our system. You've heard earlier about data from Los Angeles and Mecklenburg County, and we're definitely not even Mecklenburg, but we have just over 250,000 population. We are the 9th most populated county in the state. Kind of like most Michigan counties, around 580 square miles, so nothing unusual. Our EMS system has gone through a couple of evolutions, but we recently lost our third provider. We have 2 CAS-accredited services currently in Kalamazoo County, Life EMS Ambulance, and they have a whole table here, and we're one of our sponsors, and Life Care, part of Emergent Health Partners, covers one response to 911 calls in one township that's kind of contiguous with the city of Battle Creek in a neighboring county. We have countywide medical first responder services provided by the fire service, and in the city of Kalamazoo, we have the largest operationally integrated public safety department in the country, where all of our public safety officers are police, fire, and BLS EMS first responders. We have 7 fire departments, and this will be important in a moment, 7 agencies that have staffed fire stations, 8 that have paid on call unstaffed fire stations. So the responders have to go to the fire station to respond, although sometimes they will go directly to the scene. We have a fairly strong police AED program with all of our local and state police carrying AED and responding to echo calls from our PSAP. We have a single countywide 911 center, although EMD is done secondarily through secondary PSAPs through our 2 ambulance services. 2 hospitals that both function as regional tertiary care hospitals for roughly about a 1 million population of Southwest Michigan. Today, almost the entire county falls under what's called the Kalamazoo Valley Intergovernmental Ambulance Agreement, which is a competitively bid, performance-based, multi-jurisdictional contract that started out with the city of Kalamazoo 30-some years ago and is now expanded to nearly the entire county. Life EMS recently was reawarded that contract. So what the system change was in 2017, we have, as a medical control authority, we've always had response time standards, which is probably a little bit of a strong word, but our longstanding response time performance expectations were in the metro part of the county, kind of the traditional, as you've heard about so much today, that 8-minute or less with 90% reliability response time for ALS. And then in zone 2, which would be kind of the very rural parts of our county, a 12-minute response time with 70% reliability, meaning 25% of the time you could be well beyond that 12-minute target. In 2017, we changed over in the metro area, kicking it up by 2 minutes, which is actually 25% from 8 to 10, and for the rural area going to 14 minutes. And this is for the priority 1, primarily Charlie Delta Echo calls. So This is a very boring map of the county, which we'll come back and look at it towards the end here, but this shows the dark green areas of the urban areas. Kalamazoo is kind of in the center, Portage, Michigan, second largest populated areas directly to the south. The light green area are the rural area. You city folk from Detroit area would say, yeah, it's all rural, but we don't have cows, too many cows in the city of Kalamazoo. The area, do we have let's see, is there a laser on this? Not really. At the very north, that little upward appendage into Cooper Township, and at the south, those are the two exceptions, but otherwise that entire light green area is the rural unstaffed fire station area, and that'll be important in a moment. So when we made this change in response time, and it wasn't super radical, but you can imagine going from 8 to 10 minutes, got a lot of discussion going, and we had to work with the various stakeholders to get that in place. So we decided, let's look at cardiac arrest survival to see if that was impacted as we roll this out. So we looked at pre-2017, which was data from 2016 from CARES. We've always been fortunate enough to have, despite the medical direction, we have good responders. We've had good outcomes for cardiac arrest for many years. So we look at this comparing 2016, and we had some technical data issues, and I don't think we were quite as comfortable with the data quality in 2018. We looked at 2019 to see what that survival rate is. And you can see in Kalamazoo, overall, looking at all of our cardiac arrests, neurologically favorable survival, and that's what we really care about. Assuming they were able to pay taxes at the beginning, are they paying taxes when they get out of the hospital? We actually had an improvement overall from 10.5% up to 14%. And at that same time, you can see the state and national data were relatively flat in terms of outcomes. And then that bottom row is kind of the cherry picking subset, which you've heard about, that survival from shockable rhythms where they are witnessed. And we don't have a 250,000 population. We don't have a ton of VFib arrests. A little less than 20% of all cardiac arrests are shockable, needing a defibrillator. So if you have one or two different survivors, the numbers change. But again, we went from 47% to down to 43%, still not statistically significant, still far better than state numbers, so we were pretty satisfied with that. Looking at how we are today from last year's data from 2023, you can see those numbers have continued to hold, so we still have good numbers. We're just shy of 50% survival rate for Utstein bystander witness shockable rhythm. So that's all good stuff, and we feel pretty comfortable that at the county level, this change in 2 minutes didn't really make any noticeable move the needle much in a bad way at all with cardiac arrest survival. But one of the things we've never really been able to get a good handle on is the sub-county jurisdictions. So we have ambulance services that cover the entire county, or 2 ambulance services now that cover the whole county, but especially for some of those smaller populated townships, it's really hard when they have so few cardiac arrests to be able to see what their survival rates are. So what we did is we asked our CARES coordinator, Terry Shields, to see if we could get 5 years worth of data and see if we can't beef up those numbers to look at the outcomes in the rural, in those rural Zone 2 counties or townships and fire departments in particular. So we got the data and we kind of separated it into departments that are unstaffed stations in Zone 2 versus the staff stations in Zone 1. Not a big difference in age at all. Maybe a few more women live in, a few more females in Zone 1 in the city. Definitely a racial difference for percent white being considerably larger out in the rural areas. Bystander witnessed maybe a little bit higher, but probably not significant in the rural area. Bystander CPR rate was a little surprising that was actually higher in the Zone 2 areas. Now look at the response times here. So our median response time in the the quote unquote urban area of Zone 1, 6 minutes. In the rural area, thinking back on that map, the light green area, 10 minutes, and then looking at 90% reliability, and this is for responding to the cardiac arrest. 10 minutes, which is right on target with the 90% reliability priority 1 response time, and just a little bit above that 14-minute rural zone 2. And if you look at the numbers here, about 16% of the cardiac arrests were in zone 2. So this is what I always had the notion that the higher survivors were in the urban core. We have, every police car has an AED, they get there super fast. We have staff fire stations, the paramedic units are hovering closer by, that's where the hospitals are located. But what we found was that when we look at all of our arrests, the numbers really weren't that different between zone 1 and zone 2, 11.8 and 10.9. And our UTS was a little bit higher in the urban area, but not huge. So we think that, that I was really surprised to see the performance in these kind of rural areas, that light green area, as good as they were. We took it a step further then and looked at some townships and some jurisdictions, and this is not to build rivalry between our local governments, but our highest rates were in the survival rates for all cardiac arrests. Little Alamo Township, unstaffed fire station, 14, when you look at data from 5 years, 14% neurologically favorable walk out of the hospital from Little Alamo Township. Cooper Township, right next door. Now, a little bit of that is in the zone 1, that's where the population is, so that might have a little bit of an influence, but 15%. The southern tier of the county, 14% neurologically decent survival. No staff fire stations, on-call firefighters covering that whole southern tier. Then you compare that to the city of Kalamazoo in the center, and most importantly, where the medical director lives, Oshtemo Township. Survival rate's still very good compared to state and national numbers, but not quite as good as what we see in that area at 12%. And then the 2 most affluent local jurisdictions, Portage and Texas, again, still very good survival rates, but not as good as Little Alamo and Cooper, go figure. So I think that, there's many reasons. We just learned about this stuff as we dove into the data, but it illustrates how important having data and accurate data are in trying to understand what's going on in your system. The high survival rate in the zone 2 could be despite EMS. Those people are hardier, they're out chopping wood, milking cows or whatever. No offense to anyone that lives in a zone 2 kind of a community. Us guys in the darker green, we're just, drinking beer and watching TV, waiting to have a cardiac arrest or something. I don't know, there's a lot of factors, but again, what I think this illustrates is you can, at a minimum, we made a change in our response time. The goal was to try and we have a dynamic deployment model with our ambulance services where they're constantly relocated around the community to try and get them out further into the rural area. And we made the change, and it certainly did not show any impact on our cardiac arrest survival, and arguably it actually showed some improvements. And somewhat surprising to me, at least, was rural communities with unstaffed fire stations and longer ALS response times can still achieve very high survival rates. So with that, let me bring Doug back up, and we'll try and do some questions, and if Colby is around, we can transition to, and Doug's going to finish up, I think, with 1 or 2 more slides, but we'll transition to the panel discussion. Thank you.
And literally just like 2 more slides. This is just to give a final summary here of those 5 domains and things that you can measure that aren't just times. And again, if your system hasn't started anywhere yet, number 1, reduce the lights and siren use, because that will lead to better safety. Number 2, then start looking to decrease the priority of those low acuity calls, because that will lead to efficiency and cost reduction on top of that increased safety.